Hi, I am Dr. Vijayanandra Mashikari from Pune, and I am going to demonstrate single portal endoscopic carpal tunnel release. In preoperatively, every patient we do use sonography of wrist to see the abnormality of the nerve.
This is the marking on the flexor aspect of the forearm. So we just first mark the palmaris longus tendon, then FCR tendon. So radial to this FCR tendon, the incision should not extend because this is the branching of the median nerve here. So we will damage this nerve. So it is always ulnar to the FCR, and usually it is 1 finger breadth distal proximal to the distal palmar crease, so that if you put a scope, it is easy to manipulate the system.
5 millimeter incision, then we separate the subcutaneous tissue to isolate the palmaris longus. This is palmaris longus isolated, and then it is retracted ulnarwards to expose the deep fascia. Then we pass a scissor to form a flap which is distally based, and it opens into the carpal tunnel area. Then this flap is retracted by skin hook. Then synovial elevator is inserted in the canal to scrape the undersurface of transverse carpal ligament. These are the two dilators which is called as Hammett finder. One is 6 millimeter which is inserted into the canal first. Then second dilator 7.4 millimeter is inserted. This dilator is kept into the canal, and meanwhile we check for a white balance, the trigger, and we attach the light source to the gun. Then we remove the dilator and pass the blade into the canal and see for a transverse fiber. If there is a fogginess, then we remove the scope and dip it into the warm water saline, so that the image quality will improve. Then we confirm the distal edge of the transverse ligament by seeing the popping fat, and confirm by the tap. Cutting the ligament by engaging the blade from distal to proximal. Then go distally and cut the deeper fiber by applying the pressure on the palm so that the deeper fibers are cut. Then go proximally up to the 2/3 of the ligament, kept 1/3 ligament intact, so that you can go inside distally and see the distalmost fibers. Here the distalmost fibers are released. You can see the subacute fat is popping inside. Then release the remaining ligament. The complete release is confirmed by synovium elevator. Then we release the proximal fascia under direct vision by a blunt scissor to complete the proximal release. Check of the edges, and if this edges is U shape, then it is a complete release, and if it is a V shape, then it is an incomplete release. Suture the skin and apply the dressing. In post-op 24 to 48 hours bulky dressing. After that, Tega drum, and patient is instructed to use his hand after that for daily activity. Lastly, most important take home message: never ever skip the steps in endoscopic carpal tunnel release, otherwise you will land up in a complication. Thank you for watching this video. Stay home and be safe.